Good afternoon, everyone, and thank you so much for being here. I am so super excited about the guests that we have presenting today. These are some phenomenal individuals, and they are the absolute best in their field. And so I'm so honored that they chose to be a part of this discussion today. And I want to start by thanking our partners, our panelists, but most importantly, I want to start by thanking you as well. I know that it's a Wednesday night and you have friends and families and obligations that you could choose to attend to, but instead you chose to spend this time here with us to hear this really important discussion, and I am so grateful for that. For many Black people in our communities, the healthcare system doesn't feel like something that is built with them in mind. So it can feel distant, it can feel hard to trust, but that distrust leads many people pushing off or avoiding getting care at all. So, which means they're getting missed. And that's how small problems become larger issues. Today is about being honest about that relationship, what it feels like to access care, what works, what doesn't, and why we are falling short. My hope is that everyone in this room feels comfortable engaging in this conversation because the more honest we are about these experiences, the better we can understand what needs to change. And ultimately, the goal is to leave here with a clearer understanding of both the challenges and the pathways forward. I also want to say that if you have a question, please feel free to drop them in the Q&A section. We will be answering the questions at the end. Now I would like to introduce someone that's been exceptionally helpful during my career here in the state legislature and also helping to educate us about what he's seeing firsthand in the Black communities, and that is Dr. Tito Izard. I'm honored to introduce him as our first panelist. Dr. Tito Izard is the president and CEO of Milwaukee Health Services. This is a healthcare system that sees tens of thousands of patients each year. A Milwaukee native, he has built his career around expanding access to care in underserved communities. His work focuses on addressing health inequalities and disparities and the structural conditions that drive them, particularly in our Black communities. Under his leadership, the Milwaukee Health Services has strengthened its role as a critical provider for families who too often face barriers and are overlooked. So please join me in welcoming Dr. Tito Izard.
Senator Johnson, thank you so much for hosting this forum, this opportunity for us to be able to speak to you and to the community. I'm very grateful for this opportunity, and I think that we're all going to learn a lot from each other today.
Thank you.
So I was asked to speak today regarding some of the health issues that's impacting on the Black community. And I just want to start off just maybe taking a few minutes to kind of level set so that we all are understanding and operating with the same understanding of health disparities and health equity and kind of what this means. So for me, I use the working definition of health to mean stability within the mind, body, and spirit. And so that's what it means to be healthy. And unfortunately, for some communities, their longevity here in the United States, they haven't experienced that opportunity of stability. So I'm going to help us try to look at health from a different perspective and have us be able to better understand how health disparities comes about in our communities. So if you think about life, the beginning of life, the whole process. So life begins with metabolism. And metabolism is actually the energy exchange that happens in our bodies and around us. So if you think about our first experience of this metabolic or this energy exchange, life begins with metabolism. That is the pregnancy between the child and its mother. And in that process, the child, as it's forming in the belly, in the womb, that environment is called an ecosystem. And so there is an energy exchange that happens between the mother and the child. So energy, the whole energy process starts from the very beginning of life. And that energy process results in viable or birth of life. And so our first experience that we have, the first ecosystem that we experience is the ecosystem of pregnancy. Our second ecosystem experience is our family. So during that first ecosystem, what we take away from that is our understanding of meaning and purpose, our existence. The second ecosystem is our family. And if we think of the family serves many different roles and very important roles, but one of the most important things that we learn from our family helps us fail without retribution, without being punished. So we learn how to do things, and sometimes we win, sometimes we lose, but we learn how not to be afraid to try because the family protects us. How and why? Well, in the ecosystem of the family, when we fail, the failure isn't owned by just you, it's owned by the whole family. And so the parents absorb some of the failure that happens in their children's life. And therefore, the children doesn't have to carry that burden themselves. So this second ecosystem that we're experiencing in our family teaches us and shows us about protection. And then the third ecosystem that we experience as we grow older, we now start to interact in the world or in our communities. And that community now becomes our third type of an ecosystem. And this process is where we go beyond just our immediate family members to having interactions with others. And this is where we are mentored and we are coached by others in our community. And then this process, there's a continual energy exchange that's happening between the individual and the ecosystem that they're a part of. And so that third ecosystem process, what we learn there is what's called reciprocity. We learn that if we put out the effort, then that effort will be reciprocated. We're going to get something positive back. So if you think about health and health disparities from this new perspective, this new concept that I'm trying to help us understand, is that health is really about the interactions between the person and their environment. And this environment we're calling the ecosystem. The ecosystem surrounds us. And the ecosystem has a role, a function, a regulatory function. And that function is to make sure that we are protected. So stable ecosystems actually nurture us. And you've heard of some of the terms as far as ecosystems, the seven community capitals. So you heard of social capital and human capital and cultural capital and all those different types of capitals. But that's the role that they're doing. They serve a regulatory function to help keep us protected so that we are able to build resiliency. So in the end, to be healthy, to be stable means that you have the ability to have continuous resiliency being restored as you experience hurt and harm and stress within your life. So that's what happens under a normal circumstance. But what happens when your ecosystem doesn't nurture you? What happens when your ecosystem doesn't protect you? What happens when your ecosystem, because it's under supported and has also experienced being under resourced? What happens when the ecosystem actually starts to steal your energy away? And that's what happens in disenfranchised communities. So I like to talk about what's called the HEED population, HEED. HEED stands for Health, Education, and Economic Disenfranchisement. And so if you think about populations who would fit this category, to be a HEED population means that you have been in the United States at least into the third generation here in the United States, where each generation has experienced the continual presence of health disparities, education disparities, and economic disparities. And in that context, Heed populations live in disrupted ecosystems. Again, the surrounding environment that sometimes no longer nourishes them, but actually extracts energy from them. And so that process of heed populations, so that would be, African Americans, which I'll refer to in this discussion as American descendants of slavery, those that have had multiple generations again in the United States. You can see that in Native American populations. And the reason why I use the heat definition, because this is no longer an issue of just racism and race or color. This is an issue of heat populations, multi-generational disenfranchisement. Because also within the heat population, you have the historical Mexican Americans who were Mexicans who became Americans after the Mexican American War, and their land was taken away due to treaty violations similar to Native Americans. And then you also can include in this heat population, for example, Appalachian whites, where this is actually a regionally based heed population because of the extraction of resources and wealth from the land, leaving the people disenfranchised. So a white person who lives in the Appalachia area will experience multiple generations of health, education, and economic disenfranchisement. And so I use this because try to move it away from just conversations on race and racism, which are very important to overall health and wellness. But when we start talking about health disparities, it's not about your color, it is about this larger issue. And so all people of color may experience discrimination, but not all people of color experience multi-generational disparities in health, education, and economic disenfranchisement. So I just wanted to start off with that part of the conversation so that we all understand that issues of health disparities that we're going to learn more about really is the interaction, the metabolic energy exchange that's happening between the individual person and what's happening in their surrounding environment, which we're going to call ecosystem. So, Senator Johnson.
Thank you so much, Dr. Izard, for that information. When I first heard about HEED from your office, I thought that that was phenomenal because I had never heard of that description before. But then when I went to a meeting at Outreach Health, I heard another practitioner use the same term, HEED. And I was like, oh my God. So there's obviously something with this phrase. She did give you credit. She said that you were the person who termed it. But just hearing other people use that description and have that same discussion, I just felt you're on to something. So thank you for that. Now, it is my pleasure to introduce Dr. Jasmine Zapata. Dr. Zapata serves as a chief medical officer and state epidemiologist for the community health at the Wisconsin Department of Health and Services. She is a physician, a public health leader whose work focuses on maternal and child health, as well as the disparities that continue to impact communities across our state. Her work examines how factors like housing, access to care, and community conditions shape long term health outcomes. In addition to her role at DHS, she is also a national voice on health equity and youth empowerment. So please join me in welcoming Dr. Jasmine Zapata.
Hello, thank you so much for having the opportunity to be here. Thank you, Dr. Izard, for your wonderful comments. And thank you, Senator Johnson, for all that you're doing on behalf of Wisconsin Department of Health Services. We are truly appreciative of all of your efforts, and it's so great to be here tonight. I am a native of Milwaukee. I currently live in Madison, but I was born and raised in Milwaukee. And I'll never forget when I went to college at Marquette University, becoming aware of Milwaukee's high infant mortality rates. I was a young college student and so eager and excited to do all that I could to combat these inequities. As I went to different community meetings and community conversations, I discovered that in Wisconsin, and particularly in Milwaukee, Black babies had almost 2 to 3 times higher rates of infant mortality compared to white babies. 2 to 3 times higher rates of dying before their first birthday. This really inspired me to continue on my path into the field of medicine and public health. And after I graduated from Marquette, I attended medical school. When I was in second year of medical school, I was so excited because I got pregnant with my second child. Me and my husband were so excited. We already had a little boy, and now I was pregnant with a little baby girl. I was due on January 2nd, but on September 20th, I went into sudden premature labor. I started having sharp pains in my lower abdomen, and I rushed to the emergency room. And when they checked me, they said, "You are 10 centimeters dilated and your bag of water is bulging. You're going to meet your daughter today." And when I heard them say that, my heart leapt with joy for a second because I was going to meet my baby girl. However, then my heart sunk because I knew that it was too early and too soon. Within 2 hours of this whole process starting, I ended up having an emergency C-section, and I delivered a 1.5 pound little baby girl. Her lungs were too fragile to breathe on their own. They had to give her emergency life-saving interventions. And she ended up staying in the NICU, the neonatal intensive care unit, for 3 months. While she was there, I was passionate more than ever before to get to the bottom of why in Wisconsin, why in Milwaukee do Black mothers have higher rates of preterm birth compared to other populations? Why in Wisconsin, why in Milwaukee do Black babies have a higher chance of dying before their first birthday? And why is it due to complications of prematurity? Why are these Black babies being born too early and too soon? I saw the statistics. I read those statistics. I went on community campaigns and community engagement activities while I was in college. I never knew that it was going to be me with my own baby girl fighting for her life. I am so blessed because after multiple surgeries, after multiple life-saving interventions, my daughter survived and I was able to take her home. But there are so many other babies that don't get a chance to come home. And that was the moment that I dedicated my career to combating racial inequities in health outcomes in our population. After I graduated medical school, I had the honor of going into the field of pediatrics, and then the honor of going into the field of preventive medicine and public health. And then about 5 years ago, serving as chief medical officer and state epidemiologist for maternal and child health and chronic diseases here at Wisconsin Department of Health Services. I am the first African American, first minority, and first woman to serve in that role in our state. It's not by accident what happened to me. It was meant to fuel me to move forward so that we can see change and make change in our community. I tell you that story because there are so many inequities that we see, but instead of just letting it happen to us, we need to be able to take action and fight. Use the things that we see in our community, use the stories that we're hearing from our constituents, use the things that we're reading on the newspaper, use the statistics that we hear, not to make us feel defeated, but to empower us to make a change. If you are empowered and on fire like never before to make a change, I want you to say action right now in the chat. For those who are with us in the chat, I want you to say action. If you don't want to just hear about statistics, if you're tired, matter of fact, if you're tired of hearing about all the inequities in Milwaukee, all the racial disparities, if you're it's great that we know that information so we can be armed, but what are we going to do next? We need to take action. And so I just share that story with you to share with you in my own way how I took action. I see that Margaret is taking action, Chantel is taking action, Corinda is taking action, Amanda's taking action, 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 action. I know Dr. Tito's taking action. He's been taking action. And it's so important that we collectively work together. I want to just briefly share on behalf of Wisconsin Department of Health Services some of the things that we're doing. We talk about the inequities all the time, so I'm not even going to spend a lot of time talking about what's wrong or the inequities that we see. We know the statistics. We know there are inequities. What are we going to do about it? So I just want to share very briefly a little bit about Wisconsin Department of Health Services commitment and what we're doing just to inspire everyone to keep going in this fight. We're not going to just talk about statistics. We are going to take action. We're going to do things about it, and we're going to join together like never before. Collaboration, synergistic efforts, all of us coming together. We are strong. Wisconsin is strong. Milwaukee is strong. So just a few things to highlight from Wisconsin Department of Health Services. There is an action grant that we were able to help partner and disperse. That stands for Addressing Conditions to Improve Population Health. And that's about $9 million over an 11-year time frame. And that really focuses on Milwaukee's County Actions Team, which has helped create a network of community-based peer support groups to bolster social connectedness. That is so important, social connectedness, reduce isolation, and increase connections to social and health services. So far, this grant has established 9 community health action teams, which include 101 active community members. They have referred residents to over 577 social and health support service programs using the Community Information Exchange platform. Local and community-based organizations and healthcare systems such as Aurora Health have made over 1,650 referrals, reaching 972 clients since September of 2023. And they have done many, many other things. There's a lot of great work going to combat cardiovascular inequities to help support cardiovascular health and stroke prevention. Just a highlight, there's so many amazing things happening across our state and especially in Milwaukee. Just to highlight a few of them, the Innovative Cardiovascular Health Program addresses the needs of residents in various census tracts. There's a very high prevalence of hypertension and barriers in certain key areas. This program really focuses on 53205, 53212, and 53206, and 17 other high need neighborhoods. There is a 5 Move Every Heart Milwaukee that does tour stops within the community to offer screenings, related to social needs, blood pressure, glucose, and prostate cancer, and connections to many community health workers. As it relates to maternal and child health at Wisconsin Department of Health Services and in the bureau that I'm the chief medical officer for, we have our Title V funding, and several millions of dollars go out through the Title V Maternal and Child Health Block Grant. That really focuses on perinatal mental health, which is so important, infant mortality prevention, which I touched on briefly in my story, and adolescent mental health. We're also very excited because in Wisconsin, we were recently one of 15 states awarded the Transforming Maternal Health Funding, which is housed in Medicaid. We received about $16 million from CMS, from our federal government, to help Wisconsin invest in community-based, culturally responsive maternal health supports. And these funds are going to really work closely with our Medicaid team to focus on addressing the root causes of poor maternal outcomes, including access barriers, care coordination gaps, transportation issues, and housing, among other things. And why does this matter for Black communities? It's really important because Black birthing people face higher risk across every stage of pregnancy, from prenatal care and even postpartum. And TMA helps in this area because it helps with peer support networks, care navigation services, and aims to create better culturally competent care models. Another win that we are celebrating as well with Department of Health Services is the recent passing of the postpartum Medicaid expansion. Who heard about that in the news or is excited about that? I wonder, is it just me? Put me in the chat if you heard about that. I see several explanations, several explanations. Yes, Chelsea heard about it. Bianca heard about it. Chantel heard about it. Wanda, wonderful. And thank you to everyone here. I know for a fact there are several people here, right here on the stage today and in the chat and tuning in that played a critical role in that. Being able to extend postpartum Medicaid coverage from 60 days to a full year. In my role at DHS, I'm the co-chair of our Wisconsin Maternal Mortality Review Team. And the maternal mortality review team, we actually review hospital records, autopsy report, death certificates, family interviews of birthing people who died during pregnancy or within 1 year postpartum. There are inequities in Black people dying at higher rates. Our maternal mortality rates are higher among Black birthing people. We also see that there are several causes of death that happen after that 60-day postpartum period. So being able to collectively work together, not only us at DHS, but various community organizations, hospitals, grassroots organizations, people coming to testify and share their stories made all the difference for us being able to get that postpartum Medicaid extension, and it is going to have a direct impact on so many lives, and especially in our Black community. So that is something that we are celebrating. There's so many other things to celebrate, but I'm going to stop now and I'm going to hand it back over to Senator Johnson. Thank you once again for everything you all are doing. Do not be discouraged. Keep the hope, keep the faith, and together we will win. Thank you. Unmute.
You would think I would know how to use Zoom by now. I didn't realize I was unmuted, but I just want to say thank you for that presentation because that is so indicative of a lot of women, especially African American women. My daughter was born 3 days shy of 32 weeks. And, at the time when the situation happened, I thought it was just me. It wasn't until I got in this job that I realized, no, this happens to Black women across the board. And I think it speaks so much to us if we can't protect our children at birth, especially to their first birthday, then that kind of gives the trajectory for the outcomes of so many in our Black community. And you're right, passing that legislation on Friday was phenomenal. It is an excellent first start to making sure that we can protect our moms and our babies, especially into their first birthday, because every child that's born in Wisconsin deserves to be here, and we deserve to do everything that we possibly can to not only protect their lives, but to ensure that they get the best health care for as long as they live in the state. So now I am going to move on to questions and answers because we have a phenomenal panel and I want us to take advantage of this opportunity. First, we have a Black Caucus member, Margaret Arney. If she's available, I am going to give her an opportunity to ask her question herself.
Hello, I am glad to be here. I don't know if I can put my uh, camera on or not, but um, I also wanted to say hello, Tito, my fellow classmate from 1987 in Rufus King. Um, and it's so glad I'm so glad to be here with you. One of the things that I'm really concerned about, and it just breaks my heart, is we have so many children in Wisconsin that are lead affected. I read some statistics recently that it's around 5,000 annually. And what can families do to support their children's health? I'm hearing a lot about fresh foods, fresh fruits and vegetables, and working hard to with communities to look at what do we do when the grocery store goes away. So, as a doctor, what can you give me any hope?
Yeah, absolutely, absolutely. So, Margaret, great to hear you and see your picture there. Like Dr. Jasmine was saying, uh, one of the things that we want to make sure that we do today is to make sure that people feel activated to know what to do, how to move forward. And part of that is having forums like this so that many of us can discover that we're not alone. Like so, for example, and I know Dr. Zapata's story with her issues with prematurity and what's happening with her child, and the same thing in our family, having a premature infant and that whole process. So one of the things that, to specifically go to your question regarding lead, one of the most important things that we need to do is to make sure that all of our families are informed of what's going on, because we can pass out filters so for lead in the water. We can do all these things, but if people don't have access to that information, only certain families will benefit and other families won't. So the number one thing that we can do is making sure that we are communicating at a grassroots level with our families of what's going on, and to help especially the families that have young children under 5, for example, making sure that they have access to a primary care home, so the pediatrician or their family doctor, because you might think you're doing all the right things. You might have made sure that your walls don't have any lead paint, but if you live in an older home, it could be in the soil, right? You could have the lead laterals if you weren't aware of whether your house had lead laterals. So one of the most important things, besides just the education and the awareness that high lead levels is an important issue in our community, is making sure that our young children get tested. And so you can discuss all day long, but in the end, we need to make sure that our moms, our dads, our babies have opportunities to have access to a place where they can get regular testing, because you're not going to know until you actually know the numbers. And then from there, we can continue to expand our education and things that we can do to help that individual family based upon whether the lead level is normal and perfect where it's supposed to be. If it's a little bit elevated, try to get some mediation and mitigation actions at the home, try to discover where the lead is even coming from. And Dr. Zapata, anything you'd like to add to that conversation?
Yes, just adding to what you're saying, I agree with all of that. In Wisconsin, Black children, although they only made up about 18% of children who were tested for lead, they made up about 45% of the positive tests. So even though they only were about 18% of the children tested, their positive results, they accounted for almost half of them. And Milwaukee has the highest rates of our Black children who test positive for lead. So everything you're saying is so important. It's really important to bring awareness to families, especially living in houses or apartments that were built before 1978, and then also being aware of what resources there are. I just wanted to share, just because you mentioned that, knowing your resources. At DHS, just a few of the childhood lead poisoning prevention programs that we manage, and all of them are available to look up online. You can also go to your local public health department as well to get connected to the resources, but you can't use them if nobody knows about them. We have our childhood lead poisoning prevention program, and that supports and monitors Wisconsin's blood lead testing efforts. We also have our Lead Safe Homes program, and that helps certain families make their homes lead safe. We also do lead in water testing and remediation initiatives that offers free lead in water testing and plumbing fixes for licensed childcare centers. A lot of people don't know about that one. And then our adult lead program, which gives information and resources about adult lead exposure for workers, employers, health providers, laboratories, and researchers. So I just wanted to share that. There's a lot of resources out there, but like you said, Dr. Izard, that nobody can take advantage of those if they don't know about it. But thank you for that great question.
Yeah, and I think part of, Senator Johnson, that's probably one of the reasons I want to make sure that our take-home message is, our communities have been told so many different times that it's basically your fault if you're not healthy. But the reality is, much of health is about what's happening around us. And so that's why, I came up with this motto and started talking about, what's happening with you as an individual. It doesn't take away your individual responsibility. That still remains intact. But making sure that we understand what's happening in that ecosystem. For example, with lead, a family could do all the right things, but how would they even know that there's lead in the soil? Or unless the landlord, or if they happen to own their home, if someone didn't tell them that the lead laterals, right, were might be bad. And then if they don't have the resources in order to actually fix the lead laterals, so now you're talking about a chronic exposure issue. And we can at the clinic, we can give you, the filters, but what happens when those filters run out and it's time for the next filter, right? The system itself still needs to make sure that families are safe and protected. And that's what's happening when I talk about the ecosystem is under resourced, and it essentially, just like the Black families, it's been ignored. There's been resource extraction and exploitation that's happening to our communities and to the people themselves. And so when you have people living chronically, multi-generationally in an ecosystem, an environment that is under resourced, but then, of course, the unintended consequences is going to be the expression of health disparities. And so that's why these conversations are so important. For one, to let people know that you're not crazy. It's not just you. It's not just about what you're doing. It's not just your behavior that leads to health disparities. When we're talking about, infant mortality, if you look at breast cancer rates, you look at cancer rates, you look at heart disease, almost all of the health outcomes for African American populations, many of these conditions is we talk about the gap. So we talk about disparities. That's the gap between the majority group and the particular group we're referring to. In this case, for Black people, or more specifically African Americans. In many cases, as socioeconomic status increases, so as you improve your socioeconomic condition, higher income, elimination of poverty, in many cases, health disparities actually worsen. And most of us aren't even aware of that. So if we're teaching our children, we're teaching our families, well, just work hard, just get a good job, just don't smoke, exercise, and you can do all of those things and still have higher poor outcomes because of these other variables that are impacting and affecting your life. And if people like Dr. Zapata and myself and the healthcare community, if we don't inform people that your ecosystem is also contributing to your health disparity beyond just the behaviors that you're doing yourself, you will consider yourself a failure. And it's so important for us to teach this to our families, so that not so that you're like, oh, woe with me, but so that, like Dr. Zapata was saying, you're now empowered with information. And now you can ask your doctors, you can ask your nurse practitioners, your other clinicians, your public health officials, hey, what can I do to try to make me and my individual family healthier? And that's how we're going to address this. And then be able to put political pressure on the systems and our politicians to provide more resources to clean up the lead issues that we have in our community, or poor water, and all these other issues impacting and affecting our families.
So our second question is from Joseph Elwanger. He said, what is the current working solution for providing quality medical care for families with children that had been served at next door clinic at 28th and Clark until the clinic was suddenly closed by Children's Hospital? And he is from Micah Health Equity Task Force.
So I don't know, Dr. Zapata, if you want me to start off with that. Okay. Yeah, so that's again another important issue. Thank you for that question. I know a couple of years ago when the issue was brought to our attention at Milwaukee Health Services, Milwaukee Health Services, we're one of the five federally qualified health centers here in our communities. And our goal as FQHCs or community health centers is to make sure that everyone has access to high quality health care. And even if people are uninsured, to make sure that we offer them opportunities to access healthcare and to get enrolled with, help them find insurance, or if nothing else, be able to provide them with sliding fee scale to make their healthcare more affordable. But so when we became aware of the closure of that location, based upon the community's initiative to try to make sure healthcare remained in that community, one of our roles as a community health center was to try to make connections. And so by attending some of the community meetings and trying to make connections between the health systems that was running, was helping to financially support that institution and to bring it to the larger healthcare conversation. And one of the things that we did in that conversation was to try to connect that neighborhood and that community with the federally qualified community health center that was just within a couple miles of that location. So that's some of the things that we could do. But unfortunately, a lot of the decisions regarding where healthcare is placed in our community is based upon some of the economic conditions of healthcare reimbursement. So unfortunately, that site still closed down, but that's a challenge that we're having all over the city.
And do you have anything you'd like to add, Dr. Zapata?
It just is a hard topic when you have people that can't get the service that they deserve and that they need. So it's just heartbreaking. But that's why we continue to fight when we hear this data, this intel, when we see things happen. We have to strategize and figure out, okay, what do we need to do to move forward? And so thank you, Dr. Izard, for all of the work I know you've personally been doing on this issue, and we need to just continue to fight, raise our voices. One thing sometimes when you are doing systems change, and I know many of you can appreciate this, when you are working to change the system, sometimes you don't see immediate results right away. But I've been testifying for the last 4 years on that postpartum Medicaid expansion. It took 4 years for that win. Just because that site got shut down, we might not be able to open it up back up right away or have an immediate solution, but we can't give up. We have to be vocal about the impacts that it had. Talk to your local representatives, come to events like this, raise your voice so that we can continue to make a change slowly. So that's all I have to say about that one.
Okay, so the next question is, and I hope I don't butcher this name, Aziz Abdullah. Who leads the work locally for the action work happening in Milwaukee?
So that was Dr. Zapata. Do you know who's leading the action?
Can you repeat that? Was it just like who is leading action groups in Milwaukee?
So it's who leads the work locally for the action work happening in Milwaukee.
Oh, we can get that information. I don't have those exact names right with me right now, but we can get the information. Maybe if they do, can your team connect with our team?
Yes.
Okay.
We'll make sure we get that information.
Okay. Thank you.
And then you can follow up with our office, Aziz. We'll make sure we get that to you. Mm-hmm. Our next question is from Bianca Shaw. She said, could either of you address why it can be important for Black patients to request a physician document our charts in situations where treatment is denied, or conversely, when treatment is ordered, provided despite the patient not requesting it?
I'm not. Maybe can you read that again? Because I'm not sure. It sounds like there's more than one component to that.
So
and then Dr. Zapata will start off answering.
Sure. It says, could either of you address why it can be important for Black patients to request a physician document our charts in situations where treatment is denied, or conversely, when treatment is ordered or provided despite the patient not requesting it?
Mhm. I can start this one off just general. And as a reminder, even though we're medical doctors, we're here speaking generally for general information. We are not giving out health advice. We are doctors, but we're not your doctor right here tonight. Okay, I have to give that disclaimer. But with that being said, just in general, we know that there are inequities even in how healthcare providers chart and document about African Americans in the charts. There have been numerous studies that show there can be bias in charts related to certain minority populations. So we know that is the case. So it's really important to, as Bianca mentioned, make sure that your medical records are accurate. I have seen it firsthand where you can just look at the way someone charts about a person and you can tell, oh, they're probably a minority or they probably are from this social economic background, just the way that people, the tone sometimes that is in the charts and things like that. So it's really important just to advocate for yourself and make sure that your medical records accurately reflect what happened. One of the specific questions about like treatments that were denied and things like that, it's really important just to have accurate medical records, because when you come to your doctor, especially if it's a doctor that is seeing you for the first time, or let's say you have to go to the emergency room, something like that. It's really important when people look up your medical records, they have an accurate picture of your holistic health history. So if something is missing or there are details not there, or let's say you declined a treatment for a certain reason, that should be documented so that it can just help you have the best long-term care. So advocate for yourself. You can get your own copy of your medical record. If you go to a medical records office, you can request a copy of your own medical records. There are several ways that with electronic medical records now, patients can see their own records on my chart. So you can check those things to make sure there's not anything inaccurate. And that is a part of advocating for yourself. And I'll hand it over to Dr. Izard to finish us out on that one.
Yeah, I think that's some great suggestions to start off with. And I apologize, Bianca, if I don't understand the full question, but I think you know how to reach out to me if you had some more questions on that. But I think what Dr. Zapata was just mentioning, one of our goals that we're working on as a community health center is trying to get more of our patients enrolled with MyChart so that they can have access to their laboratory results, their test results, and even their what's called the after visit summary. So maybe not all doctor practices or provider practices may be on Epic system, but most of us have some type of electronic health record system in place that actually mandates that you actually receive what's called an after visit summary. That means every time you have a interaction with your healthcare team, if you're having a visit, they're supposed to provide you with an after visit summary, which actually gives you information regarding what the visit was about, possibly what your diagnosis is, if there's any testing that you've been done, received, and medications. So that I think that's the first step, is just make sure that they're giving you something after the visit. If they're not, you can friendly just inquire regarding do you provide an after visit summary, because that way it reminds them, for one, it lets them know that you're paying attention and you're paying attention to your health. And so maybe it was just an innocent mistake where they didn't give it to you, but you're actually watching how they respond when you, like Dr. Zapata said, when you advocate for yourself. Pay attention to the response. Is the response, oh, I'm sorry, yes, let me open the door for opportunity for you to have access to more stuff? Or is it, who are you and how dare you challenge or threaten my authority? If you have that type of provider, I say run. You don't need to be trying to fight with some clinic office. If someone is not open and receptive to you asking questions, which you have a right to do, then you have a right. Let's say you're not able to leave that practice, but then if you don't feel comfortable discussing with your healthcare provider, every clinic has some type of a clinic manager or some administrator that's over that process, or has a process for you to actually do an evaluation of what's going on. And so it's important that, like Dr. Zapata said, that you actually continue to advocate for yourself. Do not allow anyone to convince you that you don't have a right to your information, because you do.
Another question that I have is, what are the most common challenges you see patients facing when they come into the clinics, or just into the healthcare system in general, and how do these challenges affect their care?
There's lots of them I know that we could talk about. We need to have a part two to this conversation. We can have a whole session on just this one. So many things, but I can speak to one of the things that actually got me into the public health space, got me out of just the clinic walls into governmental public health. I never thought I would do anything with the government. I just wanted to be a doctor, a clinician in the hospitals and clinics. But when I saw that sometimes children and families were coming in, and because of their environment, their ecosystem, as Dr. Izard mentioned, their surroundings, they couldn't really focus on their health if they couldn't meet basic needs. If they were stressed out and worried about what they were going to eat, housing insecurity situation, racism, just turning on the news and watching Black people being murdered, that is hard to be able to deal with all of that, but then try to focus on obesity prevention or working out 3 times a week or taking your medicine. And so that was one of the biggest things that I see. It's hard for people to really prioritize and focus on their health when you have the burden of your entire family and community on your shoulders as well. And that's why we're never going to stop having conversations like these. Over to you, Dr. Izard.
Yeah, and I agree with that. And I would say one of the things that we try to do here at the community health centers, in our case, 85% of our patients actually are African American, Black and African American, and close to about 95 to 97% live at or below 200% of the federal poverty level. So when you have demographic situations where just being part of the HEAD population may introduce certain concerns that we need to pay attention to in the healthcare field, and then having the financial challenges associated with that can make it very difficult, and it can be overwhelming for families. So that's why in organizations like ours, we make it a part of not just diagnosing and treating you, but making sure we're connecting you with the nursing team that may be able to assist you with some things to make things a little bit easier, and connecting you with our human services or social work team, or our outreach workers or community health workers, because we understand that your health today, that little piece that I'm doing, like treating your hypertension or your diabetes, it's really just a small fragment of the holistic issues that you're trying to address, and all those other components that impact your health and wellness. So it's very important, and it is actually okay if it's not offered to you to be able to ask if those resources are available. And then also just integration of other services such as behavioral health and or oral, dentistry, or any other types of services that you need. We really need to, dispel the myth that it's a taboo to talk about mental health or mental illness or stress, and to understand that our patients' lives are impacted by more than just their diagnosis, and we need to appropriately treat them that way.
So I have a question from Christopher Bogan. He says, is the city of Racine a part of high infant mortality rates? The second part of his question is how often are events such as the Black History Month events held in the Racine area to inform those citizens of the resources and access? So if you want to answer the first part, then I'll answer the second.
I will say yes, Racine is actually one of the areas in Wisconsin that do see some of the highest inequities in Black infant mortality. There have been efforts over the last 20 plus years to work on that issue. When I first got started, even as a college student, the Life Course Initiative for Healthy Families was doing a lot of work in the Racine area, and there is continued efforts to work on that issue. So I highly encourage you, get connected locally with the efforts that are going on there. Reach out to your local public health department and just ask for a informational meeting. Meet with them face to face, whether it's in person or on Zoom, and ask them, what are you doing about infant mortality in Racine? How can I get involved? What funding is coming in? How is that funding being utilized? And really, and I know for a fact they're getting funding because some of that funding comes from our Title V dollars from Wisconsin Department of Health Services. So please get connected. Yes, that is a big issue in Racine, but if you jump on board, you can help join the fight.
Yeah, and so Senator Johnson, so talk about that life course initiative. It really was focusing on four communities: Milwaukee, Racine, Kenosha, and Beloit. At least during that time frame, you know, obviously when you look at southeastern Wisconsin, that's where you have a disproportionate population of the Black and African American community live in southeastern Wisconsin, and so that's some of those areas where we saw the driving of the unfortunate infant mortality rates. And so the focus has always been on, if you want to address infant mortality, you have to address Black infant mortality. And if you are going to address Black infant mortality, you have to address what it means to be an American descendant of slavery. And so for not just infant mortality, but when we look at almost all of the health disparities, it is a direct consequence of being an American descendant of slavery, because nowhere in the history in the United States have American descendants of slavery actually have had good health, because they've never had the proper treatment in the healthcare system. And so as we address this, we have to make sure that we don't assign these issues just to poverty, because infant mortality issues, like Dr. Zapata when she was a student, and just like me and my wife when we were medical students and practicing physicians, still experience infant mortality issues.
So the second part of his question was how often are events such as the Black History Month events held in the Racine area to inform the citizens of resources and access. So for the first time in the Black Caucus history, we did a tour of, of the majority minority areas in the state of Wisconsin, and we listened to what people had to say, what they wanted to see from their Black electeds, and what issues they wanted us to fight for. Tomorrow at 1 p.m., I will be giving the State of Black Wisconsin, which will address those disparities that we see in our states facing African Americans. But not only will we be doing that, we will also be rolling out the Black Caucus agenda as part of the policy platform overview and how we plan to address those issues. Now, we haven't had any other Black History Month events other than that listening session in Racine, and that was the lead up to the policy platform. One of the things that we try to do is to do events like this over Zoom to give more people the opportunity to attend, because for some people it's difficult for them to get to specific areas, and it's easier just to have these conversations via Zoom. Racine is a super important part of the state, but unfortunately, we can't go to every section and hold these events, even though we want to. So this is our way of doing that. The next question is, in hospitals or emergency rooms, doctors refuse to spend more than 2 minutes in observation and questions. How do we ensure that doctors answer questions without flippantly dismissing the patient or the advocate?
Ooh, I can start on this one. There, there's a lot we can say about this one, but number one, being able to, it's unfortunate. There was a comment that said this, like, it's sad that we have to go in healthcare settings ready to fight and advocate for ourselves. It's unfortunate that that's the way it is, but until we fix it, you need to be armed with knowledge and be able to advocate for yourself. If you feel like someone is not hearing you, being able to speak clearly and say, I do not feel like my concerns are being heard. I feel unsafe. Can I talk to a clinic manager or a nurse manager? Can I talk to someone else? Can I have this reviewed again? Speak up for yourself. You have to advocate for yourself. The second thing is we need to, from a preventive standpoint, especially when providers are dismissing people, implicit bias, things like that, we need to be really proactive. And there's a lot of hope, especially in our medical schools. There's a lot of great work in our healthcare trainee programs where they're starting to talk about social determinants of health. They're starting to talk about racial inequities, which many, many years ago, that wasn't part of traditional medical training. So they're starting to have those conversations. So there is some hope with helping our trainees. And then the other thing that we need to combat is, from a system standpoint, asking yourself, why are the providers coming in and they are so rushed and only have 2 minutes? Why are the providers so burned out and stressed out? Because the system in which they are, their ecosystem might say they have to see 50 patients in a day and they're not getting reimbursed. They don't have enough staffing. They're stressed out. And so when they're just trying to survive because the system that they're existing in isn't in its ideal conditions, then they're going to come in the room and they're not going to take that time to get to know you, to have the best quality of care. It's not always because the providers are just inherently evil and they just don't like you. It might be because they're stressed out. Healthcare providers, especially physicians, have some of the highest suicide rates in our country. I have a colleague that I had dinner with. We were mentoring students. I had a colleague in the emergency medicine field die by suicide because it's really stressful. So if we really want to attack this issue, we need to advocate for ourselves, be armed with knowledge, bring someone with you. We need to proactively train up the next generation of healthcare providers on bedside manner, on cultural competency, but also we need to fix the system that a lot of the healthcare providers are existing in, which is causing some of them to act that way. It's not an excuse for anything healthcare providers do, but we always need to be looking at root causes. But I'm gonna stop there because I could talk for hours. I'll hand it over to you, Dr. Izard.
Yeah, thanks, Dr. Zapata. This is obviously a challenge, and that's why I'm talking about what's happening in the ecosystem. Because if the ecosystem is underfunded, under-resourced, and the regulatory function of the ecosystem is breaking down, well, the impact is going to be felt at the patient level. And we could talk all day about it, but in the end, that's what is happening. So practically, what can you do as an individual patient in that situation? I would say the number one thing that you should do is do not do anything that gives them permission to essentially label you. So in other words, don't show out. Don't be very respectful, but be very persistent in what you need and do it to the best of your ability in a calm manner. Because if you go off, that is automatically going to give them and the administrators and everybody an excuse to label you. But if you are calm and you say, I'm sorry, I don't understand what my diagnosis is, would you mind explaining that to me? And they can have an attitude all day long, but in the end, they're going to stay and provide that information. If that person, just remember, if you are calm and respectful, it's going to be hard for them to call security to kick you out when you say, I don't mind leaving. I just want to understand what my diagnosis is. And they will make that person come back in, or the nurse will explain it to you in more detail. So as long as you're calm, you can ask your questions till you're satisfied, and do not give them any excuse to remove you because of your behavior. And like Dr. Zapata said, if that nurse or that doctor is unwilling to give you the answer, then you have a right in that moment to request an administrator, and you have a right to be able to stay until you get your questions answered.
And one last thing to add to that, I love how you asked, like, what is my diagnosis? It's really important to share what you're the most concerned about. What are you the most scared of? Like, talk about the things that are on your mind that you're worried about. And you can ask them, how have you how have you looked into this condition? And what have you done to rule it out? What makes you confident that this is not it? And then they can explain to you tests that you might not have even known they took when they came to draw those lab tests. They might have ordered 20 different labs and they all came back normal, but nobody explained that to you and linked it to the condition that you were most worried about. So ask about the specific things you're concerned about. And as Dr. Izard said, ask them, what is my diagnosis and what is the treatment plan for that? And what should I look for warning signs when I go home to let me know that I should come back?
Absolutely, absolutely.
So this answer is a little bit more for Christopher Bogan. This is an expansion of the question that you asked earlier. Wanda Montgomery from Black Child Development Institute, and I know what that means because she's all on people about the Black Child Development Institute. She makes sure you know what that is. The Black Child Development Institute of Wisconsin is supporting a grant through the Healthy Start for Growing Families in Children's Wisconsin. With Children's Wisconsin. Racine County is one of those focus areas. She said that you can contact her for more information at Wanda at bcdi-wisconsin.org. That's Wanda at bcdi-wisconsin.org. One other question that I have for you is, what changes could most improve how clinics serve Black patients, both in access to care and in how they receive their care once they get it? Sometimes when I hear people in this office, or just people in general, sometimes talk about how amazing programs are, my question is it Waukesha good or is it Milwaukee good? Because you can have services, but sometimes the quality of those services are not the same. So what can Black patients do to make sure that they're getting the most out of these services? And even an additional question to that, what gaps do you see in the healthcare systems and how they could be better improved for Black patients?
Well, Dr. Spot, I'll start off with that. And thank you for that question, because it's a difficult question, um, because there isn't one simple answer or simple solution to some of these things that our Black community is experiencing. So I would start off with saying, number one, clinics like mine, the reason why we're here because it is underserved, which means that there aren't a lot of doctors in the surrounding neighborhoods and the surrounding communities, or nurse practitioners, physician assistants, other healthcare providers. So there's a challenge in being able to get healthcare providers to come into this type of environment, and then to have the systems itself under resource these institutions. So, for example, as I described, having 85% Black patients and having such a high percentage of our patients who have limited financial means. Well, one of the great things that we do is we actually hire people who actually come from the same communities as our patients. That is a true blessing and is wonderful because you have people who look like you, who understands your similar types of situations, and you can potentially have that opportunity for empathy. That is great. So finding a healthcare facility that you feel you're going to get the best care. Don't make it about race. Make it about what's important to you. In the situation like I'm describing, though, while we hire 85% of our staff actually reflect the same population. But guess what? Our staff experience the same ecosystem problems that our patients experience because they live and they come from the same neighborhoods. They experience the same health disparities that our patients experience. But guess what? The funding that we receive from our different resources don't provide any level of accommodation for that. So organizations not only need, like ours, need to serve the population, but they also need to serve their staff. They need to make sure that their staff, are you getting your preventive exams done? Staff team members, you have cancer. Are you okay? Are you going to be able to get your treatment? You had a family member who was shot in the neighborhood recently. All these things happen to the staff people. And so the wellness programs need to be supported and funded by our funding institutions, by our state of Wisconsin, and by other entities. If you really want the organizations to reflect the communities that they're serving, you need to make sure that those organizations have the proper support to make sure that people can stay and serve their community in a healthy way, because the reality is they're just like the patients. And so what some people may experience is like, well, if I go to that clinic, it's more difficult. Yes, it's more difficult because everybody there is living the same life as you, but they're there to take care of you. They're there to serve you. They're there to make sure that you get the best. So personally, and the reason why I've been here 20 years, because I trust the people who I work with for 20 years, because I know for without a doubt that they're willing to do whatever they can to help you get healthier. And they're not going to disrespect you. And they are going to listen to you when you're afraid. To me, sometimes that's more important than having the waterfalls and the fancy clinic and all the fancy stuff that you may get in a different neighborhood. But that's just my opinion.
Dr. Zapata, do you have anything to add?
I was gonna say drop the mic and period, and that's it. It's after hours, so I'm acting a little silly, but that is phenomenal. Like that's so important. And it just backs up the research that I've done where I interviewed Black birthing people, Black mothers, and asked them, how can we improve inequities in birth outcomes? In particular, how can we increase trust with healthcare systems? How do we improve and transform our current healthcare delivery system? And I put the link to our article we recently published in the chat that has community identified solutions to answering exactly your question. And one of the solutions that came directly from, again, those most impacted by some of these inequities we see is make sure that the provider workforce reflects the diversity of our communities, that they want to walk in and see people who look like them. That alone is a solution. And so that's so wonderful. Dr. Izard mentioned that. But if we want to create a healthcare workforce that is diverse, we have to actually take care of them. That's phenomenal. One of the other points that the mothers in our study raised was the importance of spending time and having shared decision making and really being able to develop personal relationships. Historically, when certain populations have been mistreated in our healthcare systems, unethical experiments happening historically over the last several hundred years, we have to rebuild trust. And in order to do that, you have to be able to spend time and build authentic relationships with the patients that you're serving. So I put that in the chat, but I agree with everything Dr. Izard said. And this is such an important topic. Thank you for raising it.
Dr. Izard, I have one question left for you. And really quick, or as quick as you can. Heed, when we were in your office, you talked about those individuals and how long it would take for them to dig themselves out of poverty. With that HEED model, if they were disenfranchised in every single the health, the education, and the economics, can you talk a little bit about that? I found that to be so interesting.
Yeah, I can answer that in 1 minute, right? No, the reality. So, and thank you for the question. What's the reason why I created and I introduced it? Because we have to move away, we have to disaggregate. We have to move away from lumping minorities together with people of color, BIPOC. Those are very important terms to use when we're talking about discrimination. But discrimination doesn't always lead to a disparity in outcome, okay, or a disenfranchisement when it comes to access or an outcome. In our case, we're talking about health, we're talking about education, we're talking about economic disparities. In those cases, you have to look at people who have experienced multi generational disenfranchisement. And the problem is that as each generation moves forward, it becomes more grounded or more tethered to the bottom. It is much more difficult to try to break the cycle of a health disparity condition in the third generation than someone in the first. The reason why I use third generation is because as immigrants, when people come to the United States, almost every single immigrant, collective immigrant population experience health, education, and economic disenfranchisement. But that is during that first generation. First generation is the group that arrived. We know that as the American dream is to have your generation after you do better. So what happens is the immigrant generations, they work hard and they suffer, but they sacrifice for their children. Their children do a little bit better, and by the third generation, in other words, the grandchildren, they now start to assimilate and achieve the American dream. In most cases, too, because they tend to look more similarly to the majority population. But even since post-civil rights timeframe, so post-civil 1965, we're also seeing people of color generations be able to assimilate better than the HEAT populations. The reason is the HEAT populations I described, each one of those HEAT populations have had historical roots in disenfranchisement pre-civil rights. And that's why I use three generations. Because what happened is even though the civil rights was great, we have progress without parity. Parity means to get, things, to some level of equality. So we never addressed, we never corrected the historical injustice that happened pre-civil rights timeframe. And so what's happening is all of that disparity that existed in the HEAT populations, even though we had progress with our civil rights legislations and other things, we never addressed the disenfranchisement. So I asked a very important question to say, if wealth accrues over time, wouldn't disenfranchisement also accrue over time? So if you invest $1 now and that'll turn into $100 later, well, what happens to the divestment that happened in our communities? It actually gets worse over generations. And until that is corrected, you cannot solve health disparities if you don't address the economic and the ecosystem disenfranchisement that's happening.
Thank you for that. And I want to thank everyone for attending. I want to give you a reminder that starting at 10 a.m. tomorrow, we will have our Black Advocacy Day here at the Capitol, where individuals will come and they will advocate for their lawmakers to see changes in disparities and just to help improve the lives of African Americans all across the state. Also, at 1 o'clock, we will be diving into those disparities with the state of Black Wisconsin, and we will also be rolling out the agenda or the policy platform for the Legislative Black Caucus. So, if you guys are available and you have that extra time, I want to encourage you to tune in. This recording will also be available on my website, so you can go back and look at this as many times as you like, or you'll have the information to share. The same will be available for the state of Black Wisconsin also, to make sure that everyone gets an opportunity to participate. I want to say thank you to my panelists for this fabulous discussion. Um, we know that we can't solve these disparities overnight. We know that this has been a long systemic process, and it is going to take some hard work and time to bridge the gap in some of these disparities. But I hope it makes everyone on this Zoom feel better knowing that we have people like Dr. Zapata, Dr. Izard at the helm, making sure that they are informing us, educating for us, but most importantly, advocating for us. I was so honored, and I am not going to contain my excitement to have you guys with us today. It was truly an honor to have you here, to have this really hard discussion, and I learned a lot. And I hope that in the future we can continue to have these conversations and continue to try and make things better for Black Wisconsinites in this state. So thank you all for attending. Thank my panelists for their time and their investment. And I hope to see you guys again soon with maybe another part two of this conversation as we continue to dig into things that actually work to help improve the lives and the health of Black Wisconsinites all across the state. So thank you.
Thank you. Thank you for
Thank
everything.
you.
Thank you.